Good morning. I'd like to thank the course directors for inviting me to come speak today. And I'm going to update you on hepatitis B. First, I just wanted to kind of impress upon you the global impact of hepatitis B, which is still probably 2 to 3 times more prevalent than hepatitis C. So you can see with hepatitis B, we're dealing with billions of patients with hepatitis B, either current infection or past. And it's still the #1 cause of liver cancer worldwide. So you can see 350 million potential hepatitis B patients with potential complications of hepatitis B. Now the big thing about hepatitis B still is that 3/4 of these patients are Asian. So it's a big problem in the Asian countries, and as I'll show you, even though the United States is still considered low prevalence, we are beginning to see more problems with hepatitis B. So Asia, the African continent are very high prevalence in red. You can see that the United States is still considered low prevalence. But we live in Southern California, and in Southern California, Northern California, Houston, hepatitis B you might as well be living in Taipei or Hong Kong because we have a very high Asian population here. So our prevalence rates in areas like this are very similar to Asia. So the big question that comes up is, why is hepatitis B so prevalent among Asians? And it really goes back to how the virus is acquired. So in the Western countries, most people with hepatitis B acquired it from parenteral exposure, so either sexual contact or injection drug use or some sort of parenteral form of transmission. In the East, hepatitis B is acquired at birth. So the patients get hepatitis B vertically transmitted from their mother. And that really is the key, because if you acquire hepatitis B as a baby, the immature immune system is unable to clear the virus, and the chronicity rate is high, probably greater than 90%. Whereas if you get hepatitis B as an adult, you become very sick, very jaundiced, but that's a reflection of a very strong immune attack against the virus, and the chronicity rate as an adult is very low. So the at-risk group are really the babies, and so that's why it's now standard of care for all babies to get vaccinated after delivery. And if the mother has hepatitis B, and the OBs now screen all pregnant moms, if the mother has chronic hepatitis B, then not only does baby get vaccine, baby also gets HBeAg. And now, even the newer recommendation is to check the viral load of mom entering the 3rd trimester, and if it's greater than 200,000 IU, then you should consider 3rd trimester antivirals to decrease the viral load even more. So with these strategies, vertical transmission of hepatitis B is really dropping. And so worldwide, we've actually seen a marked decrease in new cases of hepatitis B. So the trend has been looking good overall, and this is a trend in the United States. You can see new cases of hepatitis B are dropping down. But the problem is that there's still a lot of Hep B in the United States, and what we're seeing now is not new hepatitis B in the United States from babies born, but we're seeing migration of hepatitis B, immigration from countries of high prevalence. So you can see that all the hepatitis B that we're seeing now is from immigrants from Asia, immigrants from Africa coming into the United States. And as a consequence, these are older patients. We're seeing more HCC now in the United States probably than ever. As a matter of fact, we're seeing an epidemic of HCC, and most of it is related to this pattern of immigration of hepatitis B. So the idea is, first, we have to find these hepatitis B patients. 10 to 15% of Asian Americans are probably chronic hepatitis B carriers. Many don't know that they're hepatitis B carriers. So it's incumbent upon us as caregivers to screen. And the 2 important groups to screen are listed at the top there. anyone born in a country of high prevalence, so all Asians born in Asia need to be screened. The second group is all children of parents born in high prevalence countries need to be screened. So even though the patient may have been born in the United States, if mom was from a country of high prevalence, then the baby needs, well, the patient needs to be screened. So all patients from high prevalence countries and all kids of patients, parents from high prevalence countries. So hepatitis B obviously is a condition that takes maybe 3 to 5 decades to cause problems. So if you think about that 30, that 40, that 50-year-old Asian patient is actually that patient that falls right into that window where cirrhosis or liver cancer could be problematic. So it really is incumbent upon us to screen the patients properly to make the diagnosis. Now, the problem with hepatitis B is that it's a very fluid infection. The patients can go from different phases of inactivity, immune tolerance, active hepatitis. They go back and forth between these different phases, and somewhere along the way, they can potentially progress to cirrhosis. Now, hepatitis B, unlike probably any other liver condition, can develop liver cancer, even in the absence of cirrhosis. So for other conditions, hepatitis C, alcoholic liver disease, we believe still fatty liver, predominantly you have to have cirrhosis underlying before you can get cancer. Hepatitis B, though, you can develop cancer without cirrhosis. So you have this progression that can take 3 to 5 decades, and the question is, what should we be looking for? What tests are we supposed to be monitoring in our patients to tell us who is at risk for progressing to potentially cirrhosis or liver cancer? And the big breakthrough study came out in around 2006, and it's called the REVEAL study. And this was a large study in Taiwan where patients were followed for 15 years untreated. And they found out that patients who were at risk of developing cancer were those who had a high viral load, in this case, greater than 10 to the 4th copies per ml, which translates to 2,000 IU. They also found that the patients who were at highest risk of progressing to cirrhosis were those patients with a high viral load above 2,000. So this study was very important because all other factors, whether it's ALT, gender, all these other factors fell out, but viral load was very important. So that tells us now that viral load in hepatitis B is very important and we should be monitoring hepatitis B. So I'm going to spend the second half now to just talk about the treatment of hepatitis B because we're really making some great inroads here. These are the current FDA-approved treatments for chronic hepatitis B. So there are 6 oral drugs, and the 2 drugs at the bottom are the injectable interferons. We don't much use the injectable interferons anymore because of their low efficacy and bad adverse side effects. So we're looking mainly at treating patients now with the oral antiviral drugs. And because the REVEAL study told us that viral load is important, it makes sense that the aims of antiviral therapy is to decrease the viral load, drop the HBV DNA. And like the REVEAL study told us, if we can drop that viral load below 2,000, then we can potentially prevent cirrhosis, we can prevent liver cancer. So the question that's always asked is, so who should be treated for hepatitis B? And the answer is not everybody needs treatment for hepatitis B. The indications depend on your patient. And the first thing you have to decide is you have to place the patient in one of 3 buckets. Either they're what we call an E antigen positive patient, an E antigen negative patient, or a patient with cirrhosis. So once you decide which one of those buckets are in, there are 2 blood tests that are very important to help you determine who needs treatment. One, obviously, is the viral load. because that's what the REVEAL study told us. And the other is still the serum ALT level. So the two blood tests, viral load and ALT, are very important. So the easiest way to remember this, there are all these guidelines, but they can sometimes be confusing, but the easiest way to remember it is, so if your patient is E antigen positive and the viral load is low, now the guidelines still use 20,000 IU is the threshold for E antigen positive patients, but that's slowly becoming 2,000 now. So I think for the sake of making things a little bit easier to understand, I think we're going to start using 2,000 now as the threshold, but still, especially for the fellows on the boards, it's the 20,000 that still uses the threshold for E antigen positive patients. If they have a low viral load, I give them a red light. If they have a normal ALT, I give them another red light. A patient with 2 red lights is a patient that does not need treatment, but should be monitored. And I monitor my patients twice a year, every 6 months. On the other hand, if the patient has a high viral load, I give them a green light. And if they have a high ALT, they get a second green light. 2 green lights, and this is a patient that the guidelines say we should treat. Now, there are patients that have a high viral load, a green light, yet have a normal ALT, which is a red light. So I call these patients my yellow light patients. And in the old days, the guidelines used to say you'd have to do a liver biopsy to break the tie. But if you try to convince a 20 or 30-year-old patient that you need to do a liver biopsy, they're probably going to leave your office and you're never going to see them again. So we had to come up with something that was more practical. Dr. Tong came up with a nice algorithm where he came up with a risk factor score, which is listed here. So these are readily available criteria, easy blood tests or clinical demographics. For example, if the patient is older, male gender, first-degree relative has cancer, you assign points to these different risk factors. If they have greater than 3 points, 3 or greater, then you should probably treat this yellow light patient. Whereas if they have less than 3 points, then you probably don't have to treat and you can continue to monitor. So if you have a 2 green light patient and you decide to put them on treatment, how long do they have to stay on treatment? Well, for your E antigen positive patients, you put them on treatment. The first thing that happens is their viral load will go down. Then they will normalize their ALT, and you treat these patients until their E antigen goes away, or they seroconvert. Once that happens, and that's variable, that can take 2 years, that can take 10 years, you treat them until they E antigen seroconvert, then the guidelines say continue them on treatment for another 6 to 12 months of consolidation therapy, and then you can stop. So that's the one great advantage of treating an E antigen positive patient, is that you can potentially stop. And if you do that, they'll have a pretty good durable response. Now, if your patient is E antigen negative, the algorithm is almost the same. 2,000 is a threshold now for E antigen negative patients, but it's exactly the same. If they have less than 2,000, that's a red light. Normal ALT, that's another red light. 2 red lights, you do not need to treat. However, if the viral load is greater than 2,000, that's a green light. And if the ALT is elevated, that's another green light. 2 green lights, that's a patient you should consider putting on therapy. If they have a high viral load, which is a green light, but a normal ALT, which is a red light, you have that controversial yellow light patient. You can apply Dr. Tong's risk factor score. If they have 3 or more points, you should probably treat. If they have less than 3 points, you can just continue to monitor them every 6 months. E antigen negative patients, you put on the treatment, the viral load drops, the ALT normalizes, but you have to continue them indefinitely, because these patients have been shown that if you stop treatment, the viral load rebounds very readily. So these patients, E antigen patients, have bought themselves lifelong therapy once you decide to treat them. The one instance that you could potentially stop treatment is if they happen to lose surface antigen. But as I'll explain, that's a very rare condition. But if they're so lucky as to lose surface antigen, they may have functionally, this is what we call a functional cure. They may have cleared virus, and then you can potentially stop. But again, this is very rare. If your patient falls into the cirrhotic bucket, the treatment indications are really easy. All they need is to have an abnormal ALT, and you should treat them. Or elevated viral load, and you should treat them. If they have a normal ALT and an undetectable viral load, then you can potentially monitor a cirrhotic patient. Now, the problem with the treatments, the oral treatments, is this problem with resistance. The older drugs are bad, the newer drugs are better. So the guidelines recommend using the newer drugs, either tenofovir or entecavir, if you have a 2 green light patient that you want to put on treatment. And this just basically shows you the 2 newer drugs, entecavir and tenofovir on top, are very low resistance drugs. As a matter of fact, the tenofovirs have had 0% resistance after 8 to 9 years of follow-up. The older drugs, lamivudine, are terrible. And actually, I can't stress enough how important it is never to use these drugs in hepatitis B, because you're just going to develop resistance. Now, I'm going to just take a minute or two to talk about something that's very important. It always comes up in consults, and that's this idea of hepatitis B reactivation in patients who are going to be placed on immunomodulatory or immunosuppressive therapy. And the problem is, when you place a patient on immunosuppressive therapy or immunomodulatory therapy, drop their immune suppression, it allows the virus to replicate higher. So the viral load will increase on immunosuppressive therapy. The problem is when the immunosuppressive therapy is stopped and the immune system reconstitutes, the immune system comes back and now sees this tremendous load of virus in the liver, and it attacks the virus, and then you can potentially have a very significant flare of hepatitis B. The flare can sometimes be significant enough that the patients can go into acute liver failure. So the idea is, who should we be prophylactically placing on antiviral therapy? Which patients on immunotherapy or immunomodulatory therapy need to be on prophylactic hepatitis B antiviral therapy? Because the risk is high. It can be as high as 50% in the high-risk patients. So this is a guidelines that was written by Raj Reddy. And in general, you have to kind of look at the immunosuppressive regimen that they're going to be getting. And there are high, medium, and low-risk regimens. And you have to look at the patient's serological profile. And in general, patients who are hepatitis B surface antigen positive or who have chronic hepatitis B are all considered high risk. Then you have medium risk patients and you have low risk patients. These are usually what we call the surface antigen but core antibody positive patients. So you have to just risk stratify your patient, and you have to risk stratify the regimen that they're going to be getting. And in general, once you do that, it gives you an idea of who needs to be prophylaxed or not. So the best thing that I can recommend, because obviously this is a lot to memorize, is to maybe have a card like this in your coat pocket. But this will help you risk stratify your patients into high risk, medium risk, or low risk for needing prophylaxis. So high-risk patients are the ones who have a greater than 10% of reactivation. And so in those patients, if you immunosuppress them, they need to be on antiviral therapy during immunosuppression and 12 months after you stop. The medium-risk patients need to be on antiviral therapy during immunosuppression and up to 6 months after you stop. Whereas the low-risk patients do not need hepatitis B antiviral therapy, but you need to monitor their liver tests. And if there's any transaminase bump, then you need to check for hepatitis B. So in ending, what's in the future of hepatitis B? So our current treatments are good. The oral treatments are good, but they're expensive. there's little chance for functional cure. There's the chance of rebound after you stop, and there is some toxicity associated with the current therapies. So we need a new therapy, something like hepatitis C, something that's finite, something that you can treat the patient, and the virus is gone. So there are all these new targets that are being looked at now for possible HBV cure. There's all these, enzyme inhibitors, entry inhibitors that are being looked at. The companies are looking at the virological approach, the immunological approach. Is probably going to take a combination of both to come up with a cure for hepatitis B. This is just a list of everything that's in the pipeline, but what you'll notice that most of the pipeline drugs are phase 1, if not early phase 2. So Hep B research is still in its infancy, but I think probably in the next 3 to 5 years, something good will come along. We're very good at the top row there. We're very good at getting patients into the inactive state with our current treatments. What we're shooting now for is that functional cure, something to get these patients to lose surface antigen. That's the cure for Hep B. Surface antigen is the cure. So the benefits, if you lose surface antigen, the patient is probably functionally cured. Maybe the risk for cirrhosis and liver cancer will go to 0. Maybe a curative treatment for hepatitis B will be like our current treatments for hepatitis C, a combination pill, one pill with maybe 4 different active components in it, taken for 3 months, taken for 6 months. I hope someday that I'll be able to stand up here and tell you that we have these great treatments now for hepatitis B. So in ending, untreated hepatitis B has lots of problems. Remember, we still have an epidemic, I would call, of liver cancer related to hepatitis B. Screen your patients. Decide who's a 2 green light patient versus a 2 red light patients. Obviously, treat the 2 green light patients. Hopefully someday we'll have some great medication to get rid of the virus, and I look forward to that day. Thank you.